I am Conrad Fisher. I'm the Associate Chief of Medicine for Education at SUNY Downstate School of Medicine in Brooklyn and at Kings County Hospital, largest municipal hospital in the city of New York. Welcome to nephrology. Now, nephrology, in terms of its page content, is a smaller section than ID or cardiology. The difficulty of nephrology lies in the fact that there are several equations along the line that usually kill 50% of the crowd who's watching at any particular time. Now, in nephrology, I have some good news for you. And the good news for you is that nothing in here is going to change. In other words, there has essentially been no new nephrology for many years. So whatever you're going to learn today, you're going to know it all the way. You're never going to have to learn it again. This is stop right now, and that's all you have to do. This is the last time. So in terms of nephrology, let's look at acute renal failure. Now, let's get some terminology here down. Acute renal failure, by definition, a rapid rise in a BUN and creatinine. See, everybody's got a BUN and creatinine, but they're not rising. Now, acute renal failure is not precise. Is it hours? Is it days? Is it 1 or 2 weeks? It's not clearly precisely defined. What we know is it's not years, not months. Acute renal failure, the rise in the BUN and creatinine. Now, acute renal failure has a lot of etiologies, but what we're going to divide it up into first is there problems with perfusion of the kidney, prerenal azotemia? Is there a problem with drainage out of the kidney, post-renal renal failure? Or is the problem inside the kidney itself? Now, rhabdomyolysis over several hours is because not only does the myoglobin damage the kidney itself, but what ends up happening is that myoglobin, like all pigments, are directly toxic to the kidney tubule. Contrast happens rapidly because not only is the contrast toxic to the kidney tubule, but the contrast also provokes an intense vasospasm of the afferent arteriole. See, if we look over here, we'll see this. This is what the afferent arteriole does when it sees contrast. Contrast, ooh, it's like really sour candy. This is what the afferent arteriole does when it sees contrast. Ooh, it's like sour Skittles. And what ends up happening is the afferent arteriole constricts, and not only do you have the contrast being toxic to the tubule, you have afferent arteriole constriction resulting in decreased renal perfusion. Now, over here we see aminoglycosides and post-strep. First of all, post-strep doesn't even begin to cause renal failure until 1 to 2 weeks after the infection. Berger's disease, Berger's, IgA, 1 or 2 days. Post-strep, 1 to 2 weeks after the infection. Aminoglycosides don't happen until 5 to 10 days because they must accumulate toxicity. So the difference between an aminoglycoside causing renal failure is that aminoglycosides take several days for it to accumulate. Roll in, those tubes are swollen, keep creatinine rising. Yes, but that takes 5 or 10 days. 1 dose of aminoglycoside never caused anybody's renal failure. That's why if you have renal insufficiency, do you decrease the dose or space the intervals? When you have renal insufficiency, do you decrease the dose or space the intervals? And the answer is you space the intervals to give more time for it to run out. Now, is toxicity of a medication to the kidneys, is toxicity related to the peak or is it related to the trough? And the answer is it's related to the trough. Peak is where it kills. The kill of the organism, kill. I want to see bacteria in between my teeth. I want to eat those organisms. I want to chew them up. Peak is the kill. Toxicity is with the trough. So that's why when you have renal insufficiency, you space the intervals, not decrease the dose, because you want a lower trough. Question. Why are once-a-day aminoglycosides, QD aminoglycosides, less toxic than 3-time-a-day aminoglycosides? The answer is a lower trough level. That is what allows us to prevent the You can't hear me because it is ototoxicity that comes from too high a trough. Ototoxicity from too high a trough. You bathe the ear cells of the cochlea in too high a trough and it burns them, it fries them. It basically makes crispy fried ear cells in your cochlea. So you have to decrease the trough so the cochlear cells can breathe and have some free period away from the aminoglycosides so they don't develop toxicity. On to our next slide. Now, did you ever wonder, let's see, what is the difference between renal insufficiency, azotemia, and uremia? Renal insufficiency, azotemia, uremia. Well, renal insufficiency implies that you have damage to the kidneys, but it's not bad enough to go on dialysis. Azotemia? Well, I've got azoles in my emia. Oh, I've got azoles in my emia. Well, I have azoles in my emia. But I also have urea in my emia. Although you have urea in your emia and I have urea in my emia, you don't have uremia, because uremia by definition means that you have enough renal insufficiency that you need dialysis. So renal insufficiency and azotemia mean abnormal but not severe enough to need dialysis, and uremia means so bad that you can't correct it another way. Uremia means that it's so bad that you have dialysis needing renal insufficiency. You ready? Acidosis can kill you, but you can't correct it another way. Fluid overload can kill you, but you can't give a diuretic because the kidneys are dead. Altered mental status and hyperkalemia. If you can't correct it another way and it can kill you, it's an indication for dialysis. Why do you get acidosis? Because your body makes 1 milliequivalent of organic acid per kilogram per day. 1 milliequivalent of organic acid per kilogram per day. And if your kidney is dead, you can't excrete it and you become acidotic. You get anemia. Why do you get anemia? Because we don't make erythropoietin. You get hypocalcemia because the kidney makes the 25 into 125 dihydroxy vitamin D, and the 125 dihydroxy vitamin D increases calcium absorption from the gut. If you don't have vitamin D, you get low calcium. And if you have a low calcium provokes an increased parathyroid hormone level, and the parathyroid hormone sucks all the calcium out of your bones to try to balance it out. Why do you get pericarditis with uremia? Because the pericardium does not like being bathed in renal insufficiency urea. Would you like being bathed up in your neck in urine? You would become irritated too. So the pericardium just becomes irritated the same way if you were up to your neck, say in bad body odor. You wouldn't like it either. You would develop irritation and inflammation. Why do you have infections with uremia? You have infections because even though you may have white cells, neutrophils, there are granules in the white cells. And unless you have the degranulation of white cells, it's as if you don't have white cells. A white cell that does not degranulate is like not having a white cell. Uremia inhibits the degranulation of the white blood cells. Neutrophils grab a bacteria. Come here, bacteria. Grabs that bacteria around the neck and takes myeloperoxidase, like alien juice, and burns and kills the bacteria. See, that's what white cells do. They have to grab and phagocytose. You ready? This is what happens. The T cell says like this, here's my interleukin. Hey, neutrophil, come over here. There's a bacteria entering the body. That's what interleukins are like. They're like cell phone service for bacteria, for white cells. Interleukins send a message to put the cells in action. Cells in action. Cell action, cytokine. Cytokine. Interleukins, cell phone service. And it calls the neutrophil, and the neutrophil grabs that bacteria and degranulates and sprays it with myeloperoxidase and the other acids it has. If it can't degranulate, infection. Does renal insufficiency cause increased bleeding? Or does renal insufficiency cause increased clotting? Bleeding or clotting? Which one? Renal insufficiency causes increased bleeding. Why? Platelets. Platelets have two different types of granules. They have alpha granules and they have dense granules. Dense granules have things like calcium and ATP in them. Alpha granules, why, it's the whole city of Manhattan inside each platelet. Thousands and thousands of granules, millions of chemical molecules, and basically those alpha and dense granules are what allows a platelet to make it sticky. If the platelet can't degranulate, then it's like a taxi cab that can't let in or out passengers. What's the point in having a taxi cab that can't pick up and release passengers? I have platelets, yes, but they don't do anything. They don't degranulate. Why? It's like D.K. Chesterton. Most men lead lives of quiet desperation and die with all of their music still in them. They die with all their music still in them. Hence it ends not with a bang, but with a whimper. Wow. Well, platelets in uremia are the same thing. They die with all of their music still in them in uremia. What is the music for a platelet? The contents of their granules. The contents of their granules. Well, therefore, uremia causes bleeding. Uremia-induced platelet dysfunction presents as mucosal bleeding. This presents as increased bleeding with trauma to mucosal surfaces and the skin. Skin bleeding, superficial bleeding, epistaxis, petechiae are signs of platelet dysfunction. What is the treatment for uremia-induced bleeding? What is the treatment for uremia-induced bleeding? You administer. Come closer to the television screen. Come closer to the screen. Closer, 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 closer. You give them DDAVP, desmopressin. DDAVP, desmopressin, causes the release. Desmopressin is associated with the release of the subendothelial stores of von Willebrand's factor and factor VIII. Desmopressin causes a release of these subendothelial stores because all clotting factors are made in the liver, with the exception of von Willebrand's factor and factor VIII. In the presence of uremia-induced platelet dysfunction, the administration of desmopressin can cause a sudden rise in the DDAVP release of platelet factors. Therefore, it causes increased platelet activation temporarily. Temporary platelet activation, DDAVP. Next slide. Now let's see, we have prerenal azotemia, meaning that you have a normal kidney. The kidney is normal. In prerenal azotemia, if I take the kidney out of one person and put it into another, that kidney functions normally. It's decreased perfusion. The same with postrenal, decreased drainage out of the kidney in postrenal renal failure. So in prerenal and postrenal, the kidney is intrinsically normal. Now that means that all these things, hypotension, septic shock, anaphylactic shock, neurogenic shock, cardiogenic shock, emotional shock, any cause of decreased perfusion. And remember, the kidney perceives renal artery stenosis. The kidney perceives renal artery stenosis as hypotension. The kidney perceives renal artery stenosis as hypotension because it doesn't matter what the blood pressure is in your brachial artery. All that matters is what the kidney perceives is occurring. So renal artery stenosis for the kidney is perceived as hypotension. Decreased volume of any kind, sweating, burns, any form of blood loss, decreased volume of any kind, low albumin, decreased perfusion, constrictive pericarditis, decreased perfusion. I just said the same thing in several different ways. Septic shock, anaphylactic shock, neurogenic shock, cardiogenic shock, any kind of hypotension, hypoperfusion, hypovolemia, decreased albumin, all are the same thing. Postrenal renal failure, stones. Stone where? Where can a stone cause you to have renal failure? What is the single greatest driving force for glomerular filtration rate? Is it the hydrostatic pressure inside the glomerular capsule? Is it the hydrostatic pressure inside the arteriole? Is it the oncotic pressure in the glomerular capsule? Is it the oncotic pressure inside the arteriole? What is the single greatest driving force for glomerular filtration rate? And the answer is the hydrostatic pressure. The hydrostatic pressure in the glomerular capillary going into the glomerular space is the single greatest driving force. The single greatest opposing force is the rise in oncotic pressure in the glomerular capillary. Now, if you raise the hydrostatic pressure in the Bowman space, you now create an opposition to GFR if the hydrostatic pressure in the Bowman space goes up. So if you have an obstructive renal failure raises the hydrostatic pressure in Bowman space and GFR goes down. Anything that decreases the flow out of the kidney tubule raises the hydrostatic pressure in the Bowman space and opposes filtration. The strongest factor for GFR is hydrostatic pressure in the glomerular capillary. Your mantra for today is Om Namah hydrostatic pressure. Om Namah hydrostatic pressure, affecting GFR. Postrenal renal failure, the kidney itself is normal. The kidney is normal, but there's a stone. Where stone? It would have to be in the bladder. It would have to be in the bladder or both ureters. In the bladder or both ureters. How come you can't have renal failure with obstruction of just one ureter? And the answer is that if you completely obstruct one kidney, what happens to your creatinine? Nothing. Nothing. You only need 1/3 of one kidney to live. Only 1/3 of one kidney to live because the body was designed by the Department of Redundancy Department. And the Department of Redundancy Department means that we have 2 kidneys, so if you completely obstruct one, nothing happens to your creatinine. You'd have to have a stone in both ureters or in the bladder. A stricture in both ureters or in the bladder. An obstruction in both ureters or in the bladder. A stone, a stricture, a tumor or obstruction, stone or stricture, tumor or obstruction, stone or strictures, tumors or obstruction, stone or strictures, tumors or obstruction, to block off both kidneys for post-renal renal failure. So anything that blocks both kidneys. What is the most common cause of death in cervical cancer? Well, we are in the nephrology section. So therefore, I would say it's renal failure. The most common cause of death in cervical cancer is renal insufficiency, as the cervical cancer blocks both your ureters. Now let's see. Acute renal failure. Now, remember that BUN can go up artificially with GI bleeding. All vampires have a high BUN. Why? Because protein in the gut, such as from GI bleeding, protein in the gut, such as from GI bleeding, raises the BUN. It's a protein meal. All GI bleeders have a high BUN because it's a protein meal. The same way, if you have liver disease and you don't make proteins, you have a low BUN. The same way, urea is the end product of protein metabolism. Urea is an end product of protein metabolism. Urea. So if you have a lot of blood in your gut, if you eat a lot of raw meat, you get your extra urea and your BUN goes up. If you have low protein, let's say from liver disease, you have an artificially low urea. Artificially low urea. Okay. Now, if you have a patient who has renal insufficiency, the predominant measure of that renal insufficiency is creatinine. Creatinine is the closest thing to GFR. Now, creatinine does not quite measure GFR because the only thing that truly measures GFR does not occur inside the human body. The only truly perfect measure of GFR, something that is neither secreted nor is it reabsorbed, something that is neither secreted nor reabsorbed, that is derived from the tuber root of the Jerusalem artichoke. The root of the Jerusalem artichoke is where we derive inulin. Now, inulin is something that doesn't exist inside the human body, but it's the only thing that's neither secreted nor reabsorbed. Creatinine slightly overestimates GFR because you have about 10 to 15% secretion. 10 to 15% secretion. but creatinine is the closest way to measure renal function. It'll overestimate it. The bigger the weight, yeah, I'm very big and my macho and my triceps and my biceps give me extra creatinine. And when I go like this, I get an increased creatinine because muscle mass increases creatinine. Now, if you did a bilateral nephrectomy on a dog, how fast would creatinine rise from its normal level of 1? If you had a person who is anuric, let's say you put a clothespin on my urethra, ow, how fast would my creatinine rise? And the answer is, you ready? You're on the floor and your intern says, yeah, it's okay. The patient is the 60-year-old guy. Don't worry about him too much because his creatinine was 0.5 yesterday and it's only 1.5 today. And the guy says, don't worry about it, don't worry about it. The creatinine's only 1.5. And then you come back the next day and he says, yeah, but don't worry about it. It's only 2 today. There's not that much renal dysfunction. And you say, no, Pookie. No. Your creatinine rises at a rate of somewhere between 1/2 to 1 point a day. If somebody says, oh, the creatinine only rose from this to this to this in a 2 or 3 day period, that would be the equivalent of saying you just did bilateral nephrectomy on the guy. If the creatinine the next day is 2.6, this person's going to be on dialysis. Their kidneys are 100% dead. If you do a bilateral nephrectomy on a dog, the creatinine rises at 0.5 to 1 point a day based on how much beef you got. More beef, bigger rise. Skinny little old lady, 80-year-old little old lady with no muscle mass, and you go from 1.5 to 2 to 2.6, her kidneys are 100% dead. Her kidneys are 100% dead. Remember that if the creatinine rises in a person with small muscle mass by 0.5 per day, that is the equivalent of being anuric. Now, prerenal azotemia happens because of decreased perfusion of the kidney. It does not matter why you have the hypovolemia. The same way it doesn't matter why somebody does not get enough ventilation in this room. All you know is you're not getting enough. All you know is that you're not getting enough. Third spacing of fluid is another way of saying volume depletion. See, all of these are different ways of saying the same thing, decreased perfusion into that kidney. Now, the way to be able to tell first whether someone has prerenal azotemia is to look at the BUN creatinine ratio. Now, the BUN creatinine ratio, if somebody has a problem inside their kidney, the BUN creatinine ratio, the reason that the BUN creatinine ratio is 20 to 1 in prerenal azotemia is that when you have slow flow through the proximal tubule. Here is the glomerulus, and here is the proximal tubule. Here's our loop of Henle onto the distal tubule. Okay? Excuse me, I'm more autistic than I am artistic. When you have decreased flow through the kidney tubule, you have decreased flow, decreased time. Decreased flow, decreased time. And there's more time for urea to be absorbed. If it's going through very fast, urea doesn't have time to be reabsorbed. But if it goes through very slow, there is more urea being absorbed. More urea being absorbed. But the same amount of creatinine will still be secreted. More urea is reabsorbed, the same amount of creatinine is excreted, so the BUN creatinine ratio goes up. Now, in a problem inside the kidney itself, in acute tubular necrosis, what happens is that the BUN creatinine ratio stays closer to 10 to 1. Now, in addition, when the body wants to hold on to volume, I'm hypotensive, hypovolemic, hypoperfused, I want to hold on to volume. Part of the way that the kidney holds on to volume is it holds on to sodium. So in prerenal azotemia, the urine sodium is very low. Low means less than 10, less than 20, less than 10, less than 20. Decreased urine sodium. Now, why do people do nephrology fellowships? So they could spend the entire 3 years learning how to calculate the fractional excretion of sodium. Anybody who tells you to learn how to calculate a fractional excretion of sodium is not your friend. Because in all that amount of time, you'll find that every time the fraction excreted is low, the urine sodium is low. And every time the urine sodium is high, the fraction excreted is high. But nephrologists don't do that. Nephrologists come by and they go like this. I think you need a consult. Why do I need a consult? Because you don't know how to calculate the fractional excretion of sodium. I'm the only one with a calculator in the building. You need me. You need a consult. Well, why don't you teach me how to do it? No, you'll never learn. You'll never learn it. You need me. Nah. I need to keep you ignorant and stupid, so I am necessary. I mean, no. I mean, I'm going to calculate the fractional excretion of sodium. Now, what's the difference between them and me? Because by the end of this tape, I want you not to need me anymore. The idea here is to get you so you don't need me. Eliminate the need for myself. Well, what will we do? What will you do, Conrad, if you teach us everything that you know and there's nothing left that you know that we don't know? Well, I guess I'll have to go learn something new now, won't I? I guess I'll have to go learn something that I didn't know today. And then I'll be back with Art Appreciation Week, I suppose, or something new. But the whole idea here is, by the end of this tape, to eliminate the need for myself. Fantastic. Then I'll go become something else. The urine sodium is low, the fraction excreted is low. What about urine osmolality? You see here urine osmolality? Urine osmolality. Well, let's look at this next thing. The urine osmolality. If you have a urine sodium that's low, what will the urine osmolality be? High or low? Come on, high or low? Yes, very good. The urine osmolality is very high. Well, the point is that when you have a urine sodium that is low, how is it that you can get a urine osmolality high? How do you get, I don't hear you talking. You know, I'm not a mind reader here. You'll have to tell me in words. Oh, honey, you know how I feel. No, I need to hear you say it in words. Oh, you're so insecure. No, I like to hear you say it. If the urine sodium is low, how can the urine osmolality be high? And the answer is, there's other things inside the urine besides just the sodium. There's other things inside the urine besides the sodium. So that means even though you may pull out all the sodium, there's still a much more concentrated urine. There's things in the urine like urea. Now that's a good thing to have in urine, don't you think? Urea, nitrogenous waste products. So the more concentrated the urine, the higher the osmolality. Now urine osmolality is not on a urine dipstick. Urine osmolality is not on a urine dipstick. So how do I tell on a urine dipstick when I don't have an osmolality? I want to know now. I want to know now. I can't wait. I can't wait. I need to know now. Instant gratification. You have to tell me now. And all we have is a dipstick. What on a dipstick can give you urine osmolality? The answer is specific gravity. Specific gravity is a poor man's way of being able to measure urine osmolality. And provided there's no protein in that urine, specific gravity and urine osmolality roughly mean the same thing. So I can tell right now on a dipstick. First of all, every time the urine sodium is low or high, it affects the fractional excretion of sodium. The BUN creatinine ratio is high and the urine osmolality high, the specific gravity will be high. Now, let's look at a person who's got prerenal azotemia here. The blood pressure may be high, however, the renal perfusion is still low. Look at renal artery stenosis. The blood pressure may be high, but the perfusion is low. Remember, the kidney doesn't care what the blood pressure is in the brachial artery. The kidney only cares what it is getting. So consequently, renal artery stenosis acts like hypotension. Now, hepatorenal syndrome. Hepatorenal syndrome is an idiopathic renal failure on the basis of liver disease. There are two types of renal syndromes like this. One is pulmonary renal, hepatopulmonary, okay? And the other is hepatorenal syndrome. And on the basis of liver disease, you have kidney failure. Why is that? I don't know. Well, I have deep ignorance. You don't know, and you think someone knows. I don't know, and no one knows. I do know that in hepatorenal syndrome, it falls into the numbers like prerenal azotemia. There is an intense vasoconstriction of the afferent arteriole. So you have an increased BUN creatinine ratio, a low urine sodium, a high urine osmolality. So I know that in hepatorenal syndrome, the kidney is normal. So if you fix the liver, the kidney will live. And if you don't fix the liver and you die, your kidneys are still in good shape. Give them to someone else. Hepatorenal syndrome. Fix the underlying liver disease. Now, what's the effect of ACE inhibitors on the kidney? Well, if we have the afferent arteriole into the glomerulus and the efferent arteriole, AF and EF, AF and EF, $5 Latin words for to and from, AF and EF. Affluent, to the flow. Efflux, something that flows away. The efflux of the soul is love. Flows away, comes out of. So therefore, things that dilate the afferent, if you dilate the afferent arteriole, what happens to GFR? If you dilate the afferent, it's more perfusion in. What happens to hydrostatic pressure? It goes up. Om Namah hydrostatic pressure. Om Namah hydrostatic pressure. So anything that dilates the afferent increases GFR. What is the main thing that dilates the afferent? Prostaglandins. Prostaglandins dilate the afferent. So what inhibits prostaglandins? Non-steroidals. Non-steroidals. So that's why non-steroidals inhibit the prostaglandins and constrict the afferent. Now I know what you're thinking. Oh my God, I'm never going to take Motrin again. Not for you and me. Because we have much more kidney than we possibly need. Much more. Now, if you're 78, you're down 1/3 of your kidney just for being 78. If you have diabetes, you're probably down another third of your kidney. Hypertension, another 20. If you're 78 and have diabetes and hypertension, then you take non-steroidals? That's how you get renal insufficiency. You and me, no problem. Take a piece of my kidney, no problem. 78, diabetes, hypertension, atherosclerotic disease, your kidney is dying for all the perfusion it can get. Non-steroidals can cause a bump up in BUN and creatinine in an older person with sick kidneys. If you constrict the efferent, what happens to GFR? Flow goes in, but doesn't get out. If you constrict the efferent, what happens to GFR? It increases GFR. If you constrict the efferent, you have more flow of urine out of there. You increase the GFR. What constricts the efferent? What constricts the efferent is angiotensin. Angiotensin 2. Angiotensin. Angiotensin 2 constricts the efferent. So therefore, ACE inhibitors work by dilating the efferent arteriole. Now you may say, doesn't that mean that ACE inhibitors will worsen GFR? And the answer is, yes they do. Yes they do. Now don't cry. I can see you crying. I see you rubbing your eyes out there saying, oh no, Boopy Doopy, I feel so sad for the glomerulus. I feel so sad for the glomerulus because the ACE inhibitors are going to decrease GFR. I feel so sad. Well, the interesting thing is this. People are afraid to give ACE inhibitors in renal insufficiency, but it's quite the opposite. It turns out that if you're the kind of guy that all the kind of action you get is that you can micropipette a glomerulus of a rat, and you micropipette that glomerulus, and you put a little thin slip of glass, a micropipette, into the glomerulus of a rat. And you can directly measure the intraglomerular hypertension. That if you measure the pressure in the glomerulus, it turns out that the ACE inhibitor By dilating that and decreasing the pressure inside the glomerulus, you decrease the damage to the glomerulus. It turns out that although you may dilate the efferent and decrease GFR, in the long run, you protect the kidney. For the moment, it seems like you're losing something. But in the long run, it's going to prevent damage to you. By micropipetting that glomerulus, we find that the largest contributor to long-term damage to the kidney is intraglomerular hypertension. If you dilate the efferent, you decrease intraglomerular hypertension, and you protect your glomerulus. Because this is like your brain. If you have hypertension in here, it damages the blood vessels in the cells and causes strokes. If you decrease the pressure in here, somebody could say, hey, don't decrease blood pressure. You need that blood pressure to maintain cerebral perfusion. You have atherosclerotic disease. You need hypertension. It's essential to maintain cerebral and cardiac perfusion. If you decrease blood pressure, you're going to damage the brain and the heart because you have atherosclerotic disease. That high blood pressure is essential to maintain perfusion. Essential hypertension. Essential hypertension. Did you ever wonder why it's called essential hypertension? Because 35 years ago, people used to say that you had atherosclerotic disease in your brain and your heart, and that hypertension was a normal response to it. And in order to maintain cerebral and cardiac perfusion, hypertension was essential to maintaining the perfusion. We now know that's not true. But the name essential hypertension has remained behind. Why is it essential? It's not essential. It's just a name. Why do I park in a driveway? Why do I drive in a parkway? It's just saying. Why is the smallest amount of Rocky Mountain spotted fever in the Rocky Mountains? Why does a lupus anticoagulant make me bleed? Why does disseminated intravascular coagulation Why does lupus anticoagulant, make me clot? Why does disseminated intravascular coagulation make me bleed? It's just a name. It's just a name. It was wrong. If you decrease intraglomerular hypertension, you may momentarily decrease GFR, but in the long term, you prevent renal failure. You prevent renal failure. You have a 72-year-old little old lady with a history of diabetes and hypertension. She has an increased creatinine at 2.7. What is the best blood pressure medication for her? And the answer is an ACE inhibitor. Oh no, you can't give an ACE inhibitor because you know what? She's got renal insufficiency. No, 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 no. Who needs perfusion of their kidneys more? Who needs the renal protective effect more? Oh, but it'll worsen the creatinine. No, it prevents progression of renal insufficiency. At what creatinine will you withhold the ACE inhibitor? And the answer is never. The sicker the kidney, the greater the need for perfusion. So if we look over here at the slide and we see prerenal azotemia, we'll see that if you dilate the efferent arteriole, you have a transient decrease in GFR. However, in elderly diabetic hypertensives, they in the long term will prevent the progression to uremia and renal failure. Now let's look at the strange syndrome called hepatopulmonary syndrome. The hepatopulmonary syndrome is characterized by this strange thing called orthodeoxia. Orthodeoxia. And orthodeoxia means that when you change position and sit the person upright, they desaturate. Very strange. Hepatopulmonary syndrome. Why do you get hepatorenal? I don't know. But I know that the kidneys are sick because the liver is sick. Well, now, in hepatopulmonary syndrome, why do I get renal insufficiency? I don't know. But I do know on the basis of lung disease, we're getting renal insufficiency and orthodeoxia. Now, there's plenty of people who desaturate when they lie flat. That's called orthopnea. People with congestive failure get that. But why sitting them up do you desaturate? Orthodeoxia. By a change in position, you desaturate. I don't know. You figure it out, go to Stockholm and pick up your Nobel Prize. And I'll come watch, because I don't know either. Now, postrenal renal failure is from obstruction from any reason. Cancers, BPH, the kidney doesn't care. Retroperitoneal fibrosis. What causes retroperitoneal fibrosis? What drug can cause retroperitoneal fibrosis? Bleomycin. Bleomycin. Yes, what drug can cause retroperitoneal fibrosis? Bleomycin. You remember Chemo Man? Look, it's Chemo Man. Chemo Man. Wow. Ready? Pulmonary fibrosis, retroperitoneal fibrosis, bleomycin and busulfan. It's Chemo Man. Bleo and busulfan causing pulmonary and retroperitoneal fibrosis. Wow, 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 wow. Remember Chemo Man? Vincristine, vincristine, peripheral neuropathy, peripheral neuropathy. Vinblastin, vinblastin, peripheral neuropathy, vincristine, vinblastin. Oh, Chemo Man, Chemo Man. Hemorrhagic cystitis, cyclophosphamide. See the cycles? See the cycles? Cycles? Hemorrhagic cystitis, cyclophosphamide, cyclophosphamide. It's Chemo Man. Now, what about cisplatin? Cisplatin? What organ with cisplatin? Kidneys, kidneys, cisplatin, kidneys, cisplatin. And what other organ with cisplatin? It's Chemo Man. Cisplatin, renal, and... I can't hear you. I'm sorry? I can't hear you. I can't hear you. Why can't I hear you? Because I'm deaf. Cisplatin and cisplatin. Cisplatin and cisplatin. It's Chemo Man. Cisplatin and cisplatin. Chemo Man. Cisplatin, cisplatin. Bleo and busulfan. Vincristine and vinblastin and a cyclophosphamide. Chemo Man. Now, bleo and busulfan, in addition to pulmonary fibrosis, also cause, you see here, retroperitoneal fibrosis. The two drugs that cause retroperitoneal fibrosis are bleomycin and methotrexate. Bleomycin and methotrexate and methylsurgide. Wow, methylsurgide. Well, break out my original Donna Summer albums and the Bee Gees. Staying alive, woo-hoo-hoo. Methylsurgide. Wow. Remember, before we knew beta blockers prevented migraines, before there was triptans, before there was SSRIs, before we knew calcium channel blockers prevented migraines, we used methylsurgide. Now, why am I telling you about this archaeologic fact? The Australopithecus of headache medications, the Cro-Magnon of headache medications, extinct because it's still approved for use. It's still approved for use, particularly if somebody likes retroperitoneal fibrosis. Now, neurogenic bladder is a functional obstruction. Most common cause of neurogenic bladder in the United States? Diabetes and multiple sclerosis. Diabetes and multiple sclerosis, neurogenic bladder. You see here on the stricture says bilateral. Remember, in order for strictures to cause you renal insufficiency, it must be bilateral. Now, the problem is that you don't get a rise in creatinine until you've lost the majority of your kidney. Remember, how much lung do you have to lose before you become hypoxic? How much lung function do you have to lose before you become hypoxic? 70 or 80%. How much of your kidneys do you have to lose before the creatinine rises? 70 to 80%. How much of your liver do you have to lose before your prothrombin time elevates? 70 to 80%. How much of your pancreas do you have to lose before you start to become diabetic? More than 70 to 80%. Postrenal azotemia looks like the numbers that you would get with prerenal. Decrease fractional excretion of sodium, decrease urinary sodium. Decrease fractional excretion, decrease urinary sodium. Now, how do you tell first whether or not somebody is having postrenal renal failure? The first thing is that you do an exam. You do the exam. Do you feel a big bladder? Do you, on a sonogram or a CT, find a big bladder and hydronephrosis? When you put a catheter into the person, do they give birth to a beautiful 1 liter urinoma? You intubate the penis, and out of it comes a liter of urine. Oh, look at the beautiful urinoma. Wah, wah. Gave birth to a 1 liter urinoma. I feel a bladder, a sonogram, passing a catheter. Okay, so the management of postrenal renal failure. First thing, do I feel a bladder? Sonogram with hydronephrosis, putting in a catheter. All right, so the issue is here, Wikipedia, one of the world's great textbooks of medicine here, showing a hydronephrosis. Remember, in order for it to cause renal insufficiency, hydronephrosis has to be bilateral for it to cause renal insufficiency.